start then. Nishant, can you introduce yourself?
Yeah, sir, good evening. Sir, I've completed my DM Critical Care Medicine and I'm presently working as an assistant professor in 𝑑𝒓𝒆𝒑𝒂𝒓𝒂𝒕𝒐𝒓 Medical College here in Pune.
Oh, so I frequently visit to your place, Pune, to do
Oh,
CRIT workshops. In Bharti Vidyapeeth, is Dr. Valentine Lobo there?
no, sir, Dr. 𝑬𝑫𝒰ℎ 𝒪, Dr.
Shiv
Jignesh
Kumar
Shah.
is there. Yes, Dr. Jignesh is there, na?
Yes, sir.
He knows me very well.
Okay, sir.
All right. So, uh, so you are already, you will be knowing everything of this. So,
Yes.
all right. Let's have a good interaction. We can get something from you also if we miss
Yes.
something. Kajal, can you introduce yourself?
Good evening, sir. I am like part of the Farz Academy, sir.
You're part of the team.
Farz Academy.
Okay. Who is Hemlata?
Good evening, sir. I have finished my DM Critical Care from St. John's and I'm yet to join work.
I would have then excelled my topic today if I would have known that the DM people are already here. All right. Rishi Katia, can you introduce yourself, Rishi? Rishi?
Good evening, sir. Sir,
Yes.
I have done my PDCC critical care from 𝐴IMS Bhopal. I'm presently working as critical care physician in Bhopal Memorial Hospital Research Center.
Fantastic. So you are also very well versed with ventilators and everything. So it makes my job easier. I don't have to speak much, you know. What about RH? Who is RH? I don't know who is RH.
Good evening.
Good evening.
My name is Rahila Hanif. I'm basically from Pakistan, but currently I'm in UK, and I work as a clinical fellow, senior clinical fellow at Addenbrookes Hospital, Cambridge.
Oh, great. That means you can speak in Hindustani language, Hindi.
That's
Not
okay. मैं
Hindi.
उर्दू में
What we
बात
speak,
कर सकती हूँ मैं.
देखो हम लोग जो बात करते हैं उर्दू और हिंदी मिक्स्ड ही होता है.
Exactly.
पाकिस्तान का जो डायलेक्ट है और हिंदुस्तान का जो डायलेक्ट है वो सेम है.
जी.
हम लोग ऐसे, मैं तो पाकिस्तानी लोगों से बात करता हूँ रेगुलर, उसमें हार्डली कुछ एक्स्ट्रा उर्दू ऐसी होती है कि हम लोग को समझ में नहीं आता. ऐसा तो होता नहीं है.
नहीं ऐसा नहीं होता.
हम लोग पानी कहते हैं ना, पानी इज उर्दू वर्ड, नॉट अ हिंदी वर्ड. हिंदी वर्ड इज जल. So let us start very quickly. Nishant, Hemlata, and Muhammad Abdullah. If I'm not wrong in pronouncing you, because we don't get this name very frequently in India. This type of names, because we have Shahrukhs, Salmans, and even I have heard about Julkarnain and Qurratulain, but Abdullah I'm really hearing for the first time. All right.
Yes. Good evening, our sir. I'm Dr. Muhammad Abdul, ICU specialist, master degree from 𝐵 University, working supervisor ICU in Saudi Arabia, one general hospital, Riyadh region.
Fantastic. So all of you are in ICU. So all of you are dealing with ventilators. Somebody is DM, somebody is PDCC, somebody is working in England. So the work is easier for us. So I don't have to speak much. Thank you so much. Before Christmas Eve, I think my work is easier. So I am Dr. Chatterjee. I also write Chattopadhyay. I have done my post-graduation in medicine from Royal College of Physicians of Ireland. I got my FRCP from there also. I've done my EDIC way back in 2013. I also started my career initially with anesthesia from Aligarh Muslim University, and then I also got the fellowship by the Indian Academy of Clinical Medicine. I'm heading the intensive care of Swami Dayanand Hospital, also the head of the accident and emergency there. I look after one or two hospitals, charitable hospitals in Vrindavan, Ramakrishna Mission Hospital. I am also the honorary physician and intensivist of Delhi State Cancer Institute. So this is my small introduction. So we are dealing with ventilators. I'm dealing it with for the last 15-16 years, and what I have seen that many times it is basically this complex interaction between. Can you see the slides? Can you see this slide?
Yes, sir.
This handshake between the machine and the man. Is it there? If you don't say yes, then I'll say it is not there.
Yes, it's
Yes,
there.
it's there.
Thank
Yes, sir.
you,
It's
thank
there.
you, thank you. So it's there already. See the complex interaction, and this interaction sometimes is not so smooth, and that's what causes problem. Actually, we are basically slow, sloppy, but we are brilliant thinkers. But the machine is fast, accurate. You should understand the machine is stupid. So the way you have to deal with the machines, that will tell you about exactly how the machine is working with you. Here in European Diploma Intensive Care exam, you will definitely get the scalars and the loops that you're regularly dealing with it. And very easy questions come. As we know that the scalars have flow time curve, pressure time curve, and the volume time curve. And the loops are the pressure volume and the flow volume loops. This we all know. Now, I'm sorry. When we start with when we come to by the bedside, first of all, every one of us, as you are working also in the ICUs, must be looking at the ventilator. And the patient can't say anything because the patient is either sedated or paralyzed, being ventilated, and everything of that patient is being expressed by the graphs that is being present there. So we all know that we can diagnose so many things from the flow time graphs, from the pressure time graphs, and we'll go through it very quickly. And I think don't have to explain you because you are already working in these fields. We all know that is the only graph, that is the flow time graph, is the only scalar which has two deflections. One is a positive deflection, the other is a negative deflection. The positive one is obviously the active component, that is the inspiratory part, and the expiratory arm is the passive component. And normally, they were previously when we used to use the ventilators like 𝑬𝑃2 much earlier, I'm telling. So in those times, you have square type of flow, decelerating type of flow, accelerating type of flow, and sinusoidal type of flow. Now we are more or less confined to square and decelerating flows. The point is, when we are seeing what is basically flow, we all know about it, but still to again recapitulate, flow basically the volume, the speed at which the volume is given is flow. Suppose I want to give a tidal volume 400 ml. Now, if I give it very constantly, so that becomes a square flow. If my inspiratory time is 1 second, but I am giving of that 400 ml, 300 ml in the first 0.3 seconds. And then the rest 100 ml I'm giving in the next 0.7 seconds. So that becomes a decelerating flow. That is the maximum of the tidal volume is given in the first few milliseconds of the inspiration, and the next part is giving over the longer time. So that is decelerating. Whereas if I give it the same speed, it becomes a square flow. Normally, the volume controlled ventilation, they follow a square flow, whereas when we go to a pressure controlled one, they go to a decelerating type of flow. But now ventilators are coming where all type of flows are present in all type of that is modes. That is whether it's a volume control or a pressure control. Now this is a square flow pattern. Just see, you all know that the inspiratory flow rate is constant, and the expiratory, that is the passive one, is coming up. And here the inspiratory time is tidal volume divided by the flow rate. So moment I change it to a decelerating flow, because as different ventilators are having different patterns of patent, everybody is patented in a different way. So many a ventilator, when you go to a decelerating type of flow, what will happen? They will just this inspiratory time. Just see, I'll show you. It will happen like this. That is, from the square flow I change to the decelerating flow, the inspiratory time increases.